Well, good day. Welcome everybody. First of all, I would like to wish all the people who listens to us here directly and the people who watch our video. I wanted to wish you a very good new year, a lot of happiness, obviously a lot of health, and let's hope that this year will be a great year in many aspects, and that you all will be very, very happy. And I wanted to thank also our two persons which are here invited today, Professor Ruben Mesa and Professor Serge Verstovsek. Very thankful to you that so early in January that you spared 1 hour with us in order to give us your point of view of ASH. I have been at ASH, but frankly speaking, I have not seen too many of the presentations. Mostly this is because, as you know, I'm very patient driven. I'm a patient myself. So, I don't always understand everything what you're explaining about all your good news. And I have been more concentrated on my visiting to the pharmaceutical industry to make sure that the MPN voice, the patient voice, will be heard and will be respected, and that we get a little bit more influence in that respect. So this is my short invitation. Now I would like to give the floor to you, both of you. Please just act like you would be, sitting in a coffee, taking a beer or whatever you want to take, and explain me what did you see was the great good news, or what did all happen during ASH. Please go ahead, and thank you for coming.
Well, Peter, thank you so much for the opportunity for us to get together and chat and debrief after ASH. Always a pleasure to do this with my great friend and global MPN expert, Serge Verstovsek. Maybe I'll start off by saying, just to give folks who are watching or listening to this just a bit of perspective, the meeting occurred in San Diego, and it was ironically in San Diego that I went to my first American Society of Hematology meeting back in 1997. So the same venue.
A long time ago.
A long time ago. And for folks less familiar, the American Society of Hematology is the largest hematology meeting in the world, and then some. About 30,000 attendees, very much a global meeting. It truly is the global hematology meeting. And really the key time where new findings, whether they be in biology, clinical trials, or others, are presented. The other, for reference, is the European Hematology Association that occurs then in June. Those are kind of the two tent posts. There are many other important MPN meetings, regional or country meetings, but those are the two by far largest meetings that occur, and they're about 6 months apart. So it gives kind of a nice flow to the year as well. But comparing it back with 1997, the difference is striking. First, I think if I were an MPN patient, I would be incredibly hopeful by really the scale and the sophistication of the research that is being done. Back in 1997, there was one poster session for MPN posters. There were maybe 20 to 30 posters. And there was one session where there were oral presentations from the top abstracts submitted, of which there were 8. And again, would typically be a range of things that by today's standards really would be very modest. Things such as the role of splenectomy in managing myelofibrosis, what dose of hydroxyurea to use, and things of this nature. We've evolved to this year that we'll get into better understandings of biology and risk, new targeted therapies for areas such as calreticulin, multiple new therapies in development, combination therapies for myelofibrosis, new agents in PVERA, NET, So really much to be excited about. Serge, what about yourself? What were some of your high level takeaways from ASH 2024?
First of all, thank you for participation in today's exciting commentary that we are providing here on the such important meetings. Thank you, Peter, for organizing that. So that reflection as a start of our discussion is such a good point, because at this meeting there was so much activity on MPN so that one had a hard time to actually catch up with all the oral or poster presentations, and I missed some too, because there was so much activity you couldn't get to everything. Not that there was too few, but there was too many. It's never too many, to be right, but this is the evidence of MPN rising up to the level over 20 plus years of a significance in the community of researchers or hematologists, as is for other significant and perhaps much more common conditions like lymphomas or leukemias. That gives that reflection very well in terms of a number of events, so oral presentation, poster, satellites, overlapping events that one has to pick from to choose where to go and what to do. And that also is reflected in the number, if we gonna extend it from researchers to sponsors, to industry, the number of companies that were present at ASH that sponsored a number of clinical trials and were present there to exchange experience from their view of how to develop new compounds, new drugs in the MPN field, ETPV or myelofibrosis, and to engage with the investigators face to face and arrange a number of ancillary meetings to get the best of the opportunity to have everybody present in one place, and for us together as a partners, and you'll be there as a representative of the patients to a large extent, to get that a next step to develop much more effective and more precise, like Ruben mentioned, for example, calreticulin-directed therapies in a very near future. So it was super exciting for all us engaged in this field. And I'm looking forward to new discoveries in 2025. We are at the beginning of an exciting year.
Wonderful. Well, maybe I'll just get the ball rolling. There was a range of abstracts really dealing with issues of risk, as there commonly are at these meetings. In part, with MPNs, we've always been concerned that there's a risk that the diseases can have a risk of blood clots or bleeding, and that particularly with myelofibrosis, that the diseases might lead to a decrease in survival, that they may shorten an individual's life who has such a disease, which obviously is a major concern. There was something that struck me at this year, that one particular marker of risk, we learned a bit more about the biology, but also the severity of the presence of having this mutation, which is a mutation called TP53. And this is a gene involved with gene repair. It's a gene that we know has relevance in other cancers as well. So it's probably not a surprise that it is as prognostically negative as more than one oral presentation covered. But it may have implications on what we need to consider for individuals, as well as, again, it raises the questions whether we need further therapies for developing for individuals that have these changes, and that even the data shown with stem cell transplantation really were suboptimal. Serge, what was your takeaway from some of these? And obviously, you work with a compound that has some impact kind of on this pathway as well. But the severity of this data really did catch my attention.
I think this is a really good example of evolution in understanding of the risk. And you are talking about the risk of dying, basically, survival risk in patients with advanced myeloproliferative neoplasms, myelofibrosis, and then in those that go to the transplant. In fact, this is such an interesting story from a research point of view, because to jump ahead and say that it just brings a new level of complexity to understanding the biology of the disease, because we used to be very simple in our thinking of identifying markers of a poor outcome, whether this was a size of a spleen. You mentioned splenectomy, right? So a bigger the spleen, the worse the outcome. Well, it does not necessarily need to be that, because no single factor lives out there in a person in isolation from other factors. Then we had some other findings like very high white blood cell count or very low platelets. And then we came up with the prognostic scoring systems. That's a truly excellent example of evolution from 1 factor to 4 factors, then 6 factors, then 8 factors, and then multiple prognostic scoring systems that differ among themselves, accounting for different factors to go to the prognostic score. And this is now where we are with this particular mutation that you mentioned, P53. I was actually present at oral presentations, 2 of them, that were addressing the presence or absence of P53 in the specific population of the patients. And it's not that simple. Depends when this mutation is present in the individual, at what point in time in the life of the patients, in a context of other mutations, other abnormalities in chromosomes, or a response or lack of response to certain therapies. What I'm getting to is it's not that simple, right? The biology of the myeloproliferative neoplasms, particularly advanced myelofibrosis, those patients that go to transplant eventually, is such a quagmire that you cannot, in my view, say one mutation or one clinical characteristic will lead to whatever you are talking about, survival, not survival, success of therapy or not. And that was evident in the discussions about P53 mutation. It's only in some clinical scenarios with other mutations or other abnormalities in chromosomes or other clinical scenarios where this particular mutation had a role, a negative role on the overall outcome. So it is complex field, and that is a reality. I think we, as individuals, would like to have a clear answer, yes or no, black and white. And it's not that way. That's why we have all these prognostic scoring systems. That's why, as you started your introduction, we continuously evolve. There was a new prognostic scoring system for transplant. There was a new prognostic scoring system for thrombosis in PV, right? There are all these evolutionary attempts to get us better and better in perhaps simpler way, but never ever that we can get as simple as we want, because the nature is complex and biology is evolving in the patients that progress through life with the disease. And I am afraid that we don't have a simple answer to give to our listeners. You have this, that's your outcome. You have that, that's your outcome. That does not work that way. And the P53 mutation is an example. Just on its own, it's not that bad at all. But in a context of a bad abnormalities in chromosomes, yes, it is bad, for example. So we'll see how the field evolves. With the invent of internet, now you can go online, like our doctors in Germany developed a new prognosis scoring system for transplant. Go online, punch in your characteristics, and you'll get your answer online, right? It's not that the doctor will know all these factors to put together right there in the office. You have to have a help online to calculate your risk.
You know, it's very true, you know, and I think good advice, you know, when you're a patient, you know, and again, when I see these things and I try to think about, you know, if my mom had this information, how would I explain it to her? Or again, if I had the disease, you know, what would be my takeaway? And the reality, I think that you said so well, is there are many things that really impact how severe a disease is. both in terms of the biology of the disease itself. You can look at one marker, yes, no, but there's 20 other things going on in terms of biology, or maybe other things we don't even know of that are relevant. And then second, everything else about that individual, their age, their other medical problems, their level of fitness, their cardiovascular health, their cholesterol, all these things do make a difference. So you could take the same biology of a disease and you put it in a healthy 35-year-old or a 75-year-old that has 3 stents, and they're going to behave differently. These people are different. Their livers work different, their kidneys work different, they're on different medications and others. So it's always, part of the story. That's one of the reasons that I do think it is helpful, and admittedly it is self-serving, but that it is helpful to really have as part of your healthcare team, a physician who has real expertise in MPNs, because they are different. They behave differently than lymphomas, leukemias, in part because it's a chronic disease in many ways. So you have to really be mindful of that long arc, and there is much to consider. So why don't we start with ET and PV? There are many things therapeutically for us to dig into regarding myelofibrosis, but with ET and PV, in many ways, these are one, it's the greatest number of patients with MPNs, without question. In the US, we estimate roughly 300,000 ET and PV patients to maybe 20 to 30 with myelofibrosis, 20 to 30,000. Now, those numbers may be inaccurate, but that's a rough estimate. And in the US now, we have approved therapies in ET that are few. We have anagrelide, which is approved. It lowers the platelets. It has some real limitations. It's not used to a tremendous degree. Hydroxyurea, ironically, actually not approved in ET, but certainly has been the standard from clinical trials. Older generic therapy can lower the platelets. Certainly has positive phase 3 data in its use. And there is a large amount of off-label use in the US, and certainly supported use of long-acting interferons in ET with other drugs in development that we'll get to in just a moment, such as those in the CALR space. I'd say in ET at ASH 2024, not too much that I saw that was earth-shattering. More that there is other stuff on the horizon, not yet presented at ASH, but that is of interest. We have finishing accrual, a trial that you and I started, the SURPASS ET study with pegylated interferon, or ropegylated interferon alpha 2B in ET. There is a bomedemstat that has a ongoing phase 3 trial for individuals with more stubborn ET, now being moved forward with Merck. There are early phase clinical trials using the CALR therapies, both one from Johnson & Johnson, a bispecific CALR, as well as a CALR directed antibody for those with refractory ET. So from my end, I think the biggest news in ET is really more buzz about ongoing studies that don't yet have data ready to present versus necessarily anything that was presented at ASH. But how about yourself, Serge? ET, anything that struck you?
Look at that perspective that you just gave us. And let's say that you were asked to comment on the new drug development in ET 20 years ago. And you would say, well, there is nothing I can do more than just give Hydrea or interferon. And the new drug 20 years ago was anagrelide, right? And so look where we are now. You just gave us a plethora of things that are happening, right? So it's incredible. And the point here is that from 1997 to now, first we addressed the most difficult disease, right? Myelofibrosis. And we have a first JAK inhibitor 2011, and we have 4 JAK inhibitors, and possibly new drugs are coming in the near future that may not be a JAK inhibitor type and may be combined for myelofibrosis. But in meantime, we realized that there is a room for improvement in PV, and we got approved interferon and ruxolitinib for PV. And now, finally, we are getting to the ET where there's room for improvement as well. All the 20 years plus passed, and that is reflective of our ability to develop safer and more targeted, as you just point out, calreticulin as an example, agent that may help even in what we consider benign condition of ET, which is not as benign as we would like it, but on a spectrum of ET, PV, and myelofibrosis is considered relatively benign, right? And so we are finally in a position where there is a plethora of opportunities to develop new drugs, not approved or approvable yet, but are coming forward to become possibly a new standards of care. Now, what one needs to obviously consider here is that quote-unquote benign state of the ET where the new therapies need to first show the safety, right? And then the simplicity, meaning that it needs to be easy to give because it's lifelong, perhaps, potentially. And so safety, simplicity, and efficacy, right? It's not first efficacy regardless of anything else. It's first is the safety and simplicity, and then the efficacy. So all this needs to be combined in a drug or whatever is being given to the patient, whether it's antibody or whether it's CAR T cells that are being developed for calreticulin positive patients. One needs to balance that therapeutic approach versus the population of patients that we are talking about. The relatively benign condition of ET that comes with the higher thrombotic risk, and certainly some patients can be affected by progressing to myelofibrosis. But the good news is that we spent over 2+ decades here that a threshold that gave us opportunity now to focus on new drugs, even for the patients with ET. And what you outlined will become reality. Even next year, we'll have some preliminary results from some of these studies. Calreticulin antibody is underway. The bispecific antibodies, these are the proteins that bind specifically to cells that have calreticulin on the surface in about 30% of ET patients. So it's for a selection of ET patients. But also bomedastat and interferon finally coming actually to a level where it may become approved for ET therapy as well. So we are making, perhaps you would say at a slow pace, but we are making major progress here in ET as well. And that is on the heels of a PV, right? With the JAK inhibitor approval, with interferon, now we have new therapies that perhaps will bring a new flavor of what can be done for PV patients in a simpler way, from the hepcidin mimetic to novel levels with what you would call 5 or 10 years of science fiction, like antisense, right? The targeted therapies for expression of the particular genes in PV patients that would decrease the erythropoiesis, decrease the high red blood cell count, and improve the quality of life at the same time by one injection, perhaps every month, or one injection every 3 months. And that will be all that it's necessary. That's how the field is feeling or going toward to the next level of approach to therapy rather than a cytotoxic therapy that kills cells that grow simply. So the science has evolved, even for polycythemia vera, where we have a number of approved drugs, to a level where with new scientific discoveries, we can perhaps improve the ability to target the problems in the biology of a PV in a better way to have a simpler, safer, and more effective therapy, despite perhaps being quote-unquote satisfied what we have so far. We should never be satisfied. And PV is the example of such approach, where there is, again, much more room for new drug development by learning biology of the disease in much more detail.
I think all very well said. I think one of the things that is interesting, that's evolving, is that historically we have largely treated ET in a similar fashion, regardless of whether an individual had the calreticulin mutation, the JAK2 mutation, the MPL mutation, or were triple negative, based on risk of thrombosis, symptoms, and other factors. And that, these calreticulin directed therapies really might make that different, where people who have calreticulin may have a slightly different disease, and need different therapies. And then there are drugs that are early in their testing, one from Incyte and one from a company called Ajax, that are more specific, or at least in the lab, seem more specific for the JAK2 V617F mutation. In the past, the JAK inhibitors have been active and helpful regardless of which mutation, because they all worked at the JAK2, not the mutated JAK2, but they really worked on the JAK2 pathway so that it was relevant across all three of those. So we may end up in an era where your mutation may make an impact in which therapy you get, where in the past it really has not been. So let's pivot to PV. And again, an area where we've made some important strides. We now have more approved therapies. We had ropegylated interferon alpha 2b approved back in 2021, I believe, in the fall of 2021. We have hydroxyurea is still used, although probably less because of now the advent of interferon and the positive data both with that and historically other long-acting formulations of interferon, such as pegylated interferon alpha 2a. You certainly let some of that early work, as well as many such as Dixilver, Jean-Jacques Kilajan, and others. And then ruxolitinib, which we were both involved with, that was approved in PVERA in 2014. We now have drugs in advanced testing. Again, there was discussion at this year's ASH on some of that data regarding the hepcidin mimetics, which are agents looking to help folks become phlebotomy independent. You, I know, have been involved with those trials during your time at MD Anderson. What are your thoughts on kind of that approach? I know we had no major new data at this year's ASH. I think just some update on some of the studies that have been presented. But your thought on kind of those new approaches in PV.
So yes, you are correct. And as I mentioned, there is still much more room for improvement of our ability to control and hopefully with target therapy even eliminate the disease in polycythemia vera. So the two parts here that are important. One is the spectrum of the drug development that you outlined very well, going from hydroxyurea cytotoxic therapy to just kill cells that grow, to an aglide that interferes with maturation of megakaryocytes that make platelets, and then going to interferon that alters the biology, if you like, of the bone marrow, making cells sensitive to different bone marrow milieu and not growing and normalizing in many patients what happens in bone marrow with PV, to now having those targeted therapies. So as an example, hepcidin mimetic is a consequence of realizing what actually happens with the growth of red blood cells and what is the balance of the factors that lead to uncontrolled erythropoiesis. That's that higher red blood cell count that also leads to quality of life issues. And by interfering with the iron metabolism that is altered in polycythemia vera with hepcidin mimetics, that is protein important for that balance, you would have in a patients, as you said, eliminate need for phlebotomy and possibly improve quality of life. And that is with the one injection under the skin every week. a simpler, perhaps, way than taking pills daily or even twice a day with those pills that I mentioned. And the field is evolving to this new therapies in a similar way to alter the iron metabolism that would alter the number of red blood cells in a person by decreasing the number of injections even further, perhaps once a month or once every 3 months. So there is a gain in understanding the biology of the disease that leads to the new drug development. And new therapies will lead to simplification of therapy and improvement of control of the disease and quality of life in PV. What I'd like to bring is the other side of the coin is what actually the goals of the therapy are becoming beyond just controlling the red blood cells or the quality of life or control of white cells or platelets in polycythemia vera, which also may be high. The topic of which became a hot topic, I would say, over the last few years because of the approval of interferon is the molecular response, and the PV is the best example of such a condition, where the therapies like interferon and perhaps some other novel therapies like JAK2 mutation-specific drugs, and perhaps some also proven in the long-term follow-up of patients with the ruxolitinib as well, may lead to decrease of number of cells with the mutation in the blood or bone marrow of a PV patient, which may have a consequence on what is feared by many of a decreased risk of transformation to myelofibrosis, right? There is a large group of people, 20-25% of PV patients that do transform to myelofibrosis and higher the, what we call allele burden, right? The number of mutated cells in the blood is tied to high risk of thrombosis. And so decreasing that may become, it is not ready yet, and I keep saying that for many years as a goal of a therapy, but it's becoming more common to look at that factor and perhaps judge the therapy's success with the novel ones that come along to look not only at decreasing the blood cell count that decrease the thrombotic risk, improving quality of life, but also decreasing the allele burden in a patient's, the JAK2 mutation positive cells in the blood of a patient as another factor that will not replace the goals of a standard goals of therapy, but be another factor in assessment of the overall benefit once you have multiple choices of therapy. And perhaps Peter will have here input on his view as a patient who lived with the PV of not only focusing anymore on just the blood cell count and of course very important quality of life, but also on decreasing what we call then disease burden, right? How many cells are in a person that are affected by the condition.
Yeah, well, as you know, I think well, I have it now over 30 years. I have PV, and the first thing I say, it's really true. The achievements which we had in the last, I don't know, 5 years or 8 years or something like that are absolutely tremendous. When I got diagnosed the PV, this was a black hole. You know, we had, I think, hydroxyurea, and that was basically all. Well, we had the previous interferon, but that was very difficult. So you try to stay as long as you could. You try to stay on phlebotomies in order to have your hematocrit and your platelets being controlled. Today we have a totally different situation, and that's only thanks to the work of all of you. And you know, we have not enough drugs, but we have a lot of drugs but which we can use for our illness, and especially also in PV. You know, we have improved tremendously. I mean, I'm living today on Jakavi, ruxolitinib, and I was 12 years on hydroxyurea, and you know, it just at the end it shows hydroxyurea has its limits. There comes a moment that it cannot keep your illness under control anymore, and you have to change. And I'm a very lucky person because I tolerated Jakavi, you know, tremendously. And I'm a new person as a patient. You know, I feel terribly good. My spleen has been reduced by over 50%. It's still reducing, you know, after nearly 1 year taking the product, and you simply feel much better. Now, it is obviously that we have a lot of PV patients. They have similar results, but they are on these side effects, on the symptoms. They still have very huge problems, and this is what makes me, very enthusiastic when you hear all what is being taught, explained at ASH in San Diego, and what you're explaining now. But you're very hardworking, really, to go after this, and I think this is extremely important and very stimulating when we can see that you're trying to get more onto the symptoms and to try to find different ways besides not only the cytoreduction, but we have other ways to control the illness. And in general, I think MPN is a family which is changing very fast. The companies are changing. Before we had Imago, now it's Merck. We had MorphoSys, now it's Novartis. We had Protagonist, now it's Takeda. And I think what also has been, if I look back on ASH of last year, sorry, the year before, 2023, we were all very helpful on navitoclax and other combinations. Navitoclax, has been closed in the meantime. Well, we all know the story of the MorphoSys Novartis new product. So I think it's coming from also that the regulatory people, they have changed also a bit their opinion. I don't know if I'm right, but this is the information which I'm getting, is what they're saying, that we should not treat only, as the cytoreduction, but we also have to treat the symptoms. And they say they would like to see more products which are going to the symptoms. And this is exactly, the way which you are describing what you're doing now, but you're trying to find, these ways to do it. So I am very, very happy, and I'm, okay, I don't know how many years, we can have this talk at the beginning of the year, but, I'm really looking forward. And also I think we might not have any new treatment coming out in the next 2 years, most probably, but I think this gives us also time to work much more on the treatments which we have now, and to learn how to use them, and to learn, how we could, maybe find some additional treatments which can help the existing products. That's how I see it from a patient view.
So all very fair, Peter. Sometimes I think when you have the disease, there's no question that all of this seems both very slow, and frustrating, in that, again, drugs change hands multiple times in terms of companies. There's the regulatory process. I would kind of take a slightly different view. All of that is true, but to some degree, as they say, it's like the sausage being made. So it's, for some people it's just too much detail. But I would have these as kind of takeaways. One, if a therapy ends up being developed that has dramatic effectiveness, its path to approval probably would be very quick. I think the closer they are to being incremental, smaller changes from where we are, the longer they take. And we have that as an example. Imatinib in chronic myeloid leukemia was almost miraculous in how effective it was compared to where we had been. And it got approved very, very quickly. And I think if any of the things that we don't have data on yet, or new things that are not yet being tested have that kind of impact, we probably would see all of that move fairly quickly. I think, again, we now have multiple companies really trying specifically to develop drugs for MPNs, and that's a real sign of progress. One of the key things I mentioned at the beginning of this discussion back in 1997 is no one was trying to develop drugs for MPNs. Everything we discussed, where we were trying to use drugs being developed for other reasons for MPN patients to see if they could help. nor did we have the information on the biology of MPNs to really help guide us. So maybe let's take this and in the time we have remaining, kind of then move to myelofibrosis. Myelofibrosis is, the least common of the MPNs, but is really important. One, we think that overall in myelofibrosis, the disease is more severe. There's a greater likelihood that the disease could shorten someone's life. And overall, the suffering with the disease tends to be more. Now, there are exceptions to all of that for any particular patient, but is true overall. Likewise, can represent progression of the disease and can be life-threatening kind of even in that phase. Now, that again is an example. When Serge and I started our careers, there were no approved therapies in myelofibrosis. And we, along with many other colleagues and companies, multiple switches along the way, now have 4 FDA-approved therapies in myelofibrosis, 4 JAK inhibitors. Ruxolitinib, Serge led that program. I played a key role. It was the first of these to be approved, then fedratinib, then pacritinib, and then momelotinib. And they're all very helpful drugs, but they do have significant overlap in terms of their benefits. They can shrink the spleen, they can help symptoms. I think in patients who respond well, there's probably data for all 4 that patients who are responding well probably do live longer. And I think without question, having cared for many patients over the years, this is true. With the most recent of these approved, momelotinib and pacritinib, having important additional benefits of being safely used in patients with low platelets or with anemia with pacritinib, or helping anemia with momelotinib, kind of expanding that capability. I think at this year's ASH, and I think one of the themes over these meetings has been these are a great 4 as a base. There are others still trying to be new JAK inhibitors in this space. There was a drug from China that was presented. The data were impressive, although the number of patients were small. I think there was some clear desire to see both larger numbers and kind of reproducibility of that, to see, are there other JAK inhibitors that are standard JAK inhibitors that are worth testing? I mentioned earlier that there are the targeted JAK2 V617F inhibitors that no data at ASH, but are early in their testing and in clinical trials. But that the great interest is in combinations. And there have been a bunch of combinations that have been tested before this, many of which without significant benefit. Others that recently have shown real benefit, but still have not succeeded in the regulatory gauntlet with navitoclax, as you had mentioned. We'll get around to pelabresib in a moment. But maybe to be sure that we cover with enough time, one of the ones that really did have perhaps the greatest impact at this year's ASH is one that Serge is involved with, which is naftamadlin. Now, in full disclosure, Serge is the chief medical officer for the company that makes naftamadlin. But I could say, as someone who is not does not have a financial stake in Kartos, the company that does that this data was of significant interest and is certainly a strong contender for combination approaches. Serge, why don't you just share with folks just a little bit, what are some of the takeaways you think that patients should know about the numerous abstracts you guys presented on naftamadlin?
So thank you, Ruben, and certainly that disclosure is very important as a chief medical officer of a company called Kartos that is developing naftamadlin. But let's step back a little bit and say what needs to happen for a drug to be new drug for myelofibrosis to be approved? And you mentioned regulatory bodies and a regulatory path. So very simple, right? You have to have a drug that is really good in what it does. That would be improving quality of life, control the spleen and symptoms, possibly changing the biological parameters, talking about the disease modification in myelofibrosis. It has to be tested in a population of the patients where there is a need to be tested. An example is testing the drugs in the patients that have never been treated with any JAK inhibitor and treat everybody with a new drug on top of a JAK inhibitor. Perhaps it's not the best way to prove its value because many will do well just with the simple JAK inhibitor on its own. They do not need a combination, for example. Or the number three, so the quality of drug, the population of the patients, and number three is the design of the study, right? You have to design it and execute it in the best possible way to satisfy that approvability requirement, a rigor of the FDA to prove the point that it's safe, effective, and it has to be simple to give. And this is what we have here with our new approach in not treating patients with naftamalin in combination with ruxolitinib from the very first day of a JAK2 prescription. So it's not ruxolitinib plus naftamalin for everybody who comes through the door and it's in need of a therapy. We select patients only that have a suboptimal response to ruxolitinib. So you give a chance ruxolitinib to work. If it's not working good enough, then you are a subject to a clinical study. And then you give a medication like naftamalin that would be providing those benefits on the spleen and on the symptoms, and possibly also changing the biology of the disease at the same time. So good drug in a population of the patients with a study design that makes sense. Those are the three factors that we try to satisfy within Cartus and with naftamalin. And you mentioned we have oral presentations showing that this particular drug alone in people who were resistant and refractory to JAK inhibitor, so after JAK inhibitor, when there is no real therapy approved at all after JAK inhibitor in the patients very advanced, the naftamalin has shown those characteristics to be active, to be safe, effective, and also changing the biological parameters, the bone marrow fibrosis, the cytokines, and allele burden in patients in the resistant refractory setting. So we have those characteristics that I would feel very strongly will lead us to a success. And the study, phase 3 study for its approval is underway globally. But there are others, and there are others that are following, like a PIM inhibitor, for example, that is following closely behind. And then there is a BET inhibitor from Incyte company that has also been presented in oral sessions. And these are two other drugs that are relatively well advanced in their attempts to find the population of the patients that these drugs would be the best to evaluate, to design the study that would prove its value. And of course, the drug needs to be effective and safe at the same time. So these are two other drugs that are following. And then there was a plethora of other, I would say, pilot studies presented in oral sessions throughout the meeting at ASH on myelofibrosis, from antifibrotics to cellular therapy with so-called Tregs, the cord blood T lymphocytes that perhaps may alter the inflammation in the bone marrow of the myelofibrosis patients, and others more unusual ways of tackling the problem of altered biology in myelofibrosis patients. So very exciting to see new attempts, because we had a year where navitoclax and pelabresib and those, as an example, had some difficulties, and we do not expect those drugs to become anytime available as approved drug. And navitoclax actually program was completely shut down. Ruben, what's your take on that?
Well, it's, I'd say, everything you said, I think is very accurate. And again, I think how you've described where we stand with naftamadlin to be very accurate and fair. I think there is certainly a lot of interest around that. The PIM inhibitor, so that is nuvisertib, a TP3654, and I've been involved with those studies that are very interesting. They have a very interesting impact on the cytokine and the inflammation in the disease. They're helpful for symptoms. And again, we think that these things can be indicative of biological response, and those larger studies that'll be forthcoming will be really, really interesting. There was further updates on pelabresib. That drug is still actively being tested. The Manifest-2 study was both a positive study, yet did not reach kind of the threshold for FDA approval. FDA approval is its own specific kind of set of milestones that you kind of agree to for a trial to meet kind of prior to the trial starting. So there's a lot of discussion, again, in our field, what benefit does a combination need to have compared to a single agent JAK inhibitor to be sufficiently beneficial for patients to have it be worth their while? And with many questions that derive from that, is that if a combination was approved, is it helpful for everyone? Is it helpful for a subset of people based on features that they have, based on their biology of the disease? I think that too is very much of an active discussion. But without question, that class of BET inhibition, of which pelabresib falls into that class, is of great interest. So again, will pelabresib get approved? It may well, and again, it's still very excited about that approach. I'm mindful, fedratinib, pacritinib, and momelotinib, all changed hands along the way. Pacritinib and fedratinib both had periods where they had clinical holds where there were issues and they were resolved. So these things, it clearly can be able to be worked out. As I mentioned, those are the furthest along. The things are earlier in development, again, really interesting, particularly given the spread of different things being tested. Working on the immune system, and those things that are not yet in abstract form, that are really early in testing. The specific JAK inhibitors that I had mentioned, the calreticulin inhibitors that we discussed in the ET part of our discussion, are also being tested in myelofibrosis. Again, with different goals, but the same sort of concept for them. So I know we're basically almost at time. Serge, any final thoughts on what you're the most excited to see in 2025?
Well, the maturation of the efforts to develop these drugs and the conduct of the phase 3 studies are the goals for me to see in 2025, and identification among the plethora of those drugs that are being tested early on, to see what will transpire as the good leads for efforts to develop it further by the end of 2025. So a lot to expect next year at this discussion. I think we'll have an exciting ASH 2025 and a very active year. Peter?
Thank you very much. It's been a very, very stimulating discussion. Thank you. That was absolutely great. And especially coming from these two professors, you have been involved in most of the treatments which we are having in MPN. So, we are working together since many years, and thanks to your work and the work of your colleagues, we do have all the possibilities which we have today, and that every time when you come back from ASH, you can see again that the hope is rising up, and that you're very hardworking in order to get positive news for us. In the name of all the patients, I wanted to thank you for this dedication which you are showing here day by day. to you and your colleagues. And we are very, very optimistic on that. And I agree with you. I'm sure that next year, the ASH 25, we will have some even more positive news. And I said, so we are really at time. It's a clock, so I don't want to stress you more. I know you have already a full program. Thank you very much for being here. It was a great pleasure. I'm very optimistic, and I will transmit this optimism to the patients in order that they can follow up things which are going to happen. Thank you, and have a great year. Lots of health, good luck, and a lot of happiness. Thank you.
Thank you both. It was great.
Bye-bye. Care.
Bye-bye.